Josh Mandel. Josh, can you introduce yourself briefly?
Sure. So I'm Josh Mandel. I'm a physician and a software developer. And since I graduated from medical school, I've been working on various projects in healthcare informatics with the goal of making it easier for developers to build new functionality that integrates into the healthcare system. Sure. So when the history goes back for me to about 2010, I was graduating from medical school, and as a medical student, I had been very interested in making the computers do more for me and for my classmates and for clinicians and patients. And I had learned about this field of medical informatics. So on my way out of medical school, I was really excited to join a team that was just coming together at Harvard Medical School on this new research project called SMART, which was funded by a grant from the federal government with the goal of building an app platform. So building a way for developers to connect to the data inside of healthcare systems and present apps that doctors and other clinicians and patients could use to make sense of data in the medical records. And when we started this project in 2010, we really started from scratch. We said, what would a modern REST API look like for working with healthcare data? What are the kinds of data we care about? And we made a list: medications and problems and labs and allergies and so forth. And we started asking, okay, well, what are the detailed data models? What are the attributes of each of these data types that we'd want to be able to work with? And early on, we hosted some sample data that we put together working with a number of partners. We integrated into a couple of open source electronic health record systems to give developers a picture of what this would look like. And we held a competition asking for folks to build apps and share their ideas. And we got great feedback from the developer community saying, we wish we had this kind of interface in the real world, inside of real healthcare systems. At the same time, when we had conversations with some of the health IT vendors that make big electronic health records that are in production at some of the major hospitals and healthcare centers, the feedback that we got was, we're really excited about this technology, but we're not going to go and implement a whole new set of capabilities just to align with this research project at Harvard. What we really need is a set of standards that we can agree on as an industry to support these apps, but also to support other use cases as well. So that was about when I started getting involved in the standards development process and got involved with the development of what was then the very early days of FHIR, the Fast Healthcare Interoperability Resources standard. Sure. So early in the project, we discussed a number of ways to improve access for developers to clinical data. And we settled on a relatively small scope to begin with, which was focused on building apps that could integrate with the EHR and mostly have access to read data from inside of the system. So data liberation, exposing what was in those EHR systems and making sure that apps could take advantage of those data and present a user interface. And we were able to make a lot of progress by keeping the scope pretty narrow. So the kinds of things that we left out of scope from the beginning were being able to write complex data back into the EHR, being able to integrate deeply with the clinical workflow by restricting where and when an app gets presented. We left out of scope how multiple apps might run at the same time and interact with one another through sort of real-time communications. We left that all out of scope and said, can we just solve the problem of putting one app at a time inside of one EHR at a time with a consistent interface? And the exciting thing is, because we were able to keep the scope pretty narrow, we really focused on things that could be done without a lot of new research efforts, things that could be built into the production systems in the real world. We've started to see uptake of this technology from some of the biggest health technology vendors. So that now if you go to the healthcare trade show and you look at some of the big vendor systems, they are announcing support for, and now they have support rolled out in production for these capabilities inside of their health records that clinicians use, and also inside of their patient portals that patients use. So we're really starting to see it become a reality for these apps to get access to data and to be able to display innovative user interfaces and make recommendations for clinicians and for patients as well. So we're at the point right now where our narrow scope has become a reality, and it's very exciting to think about what comes next, how we can begin to tackle some of those issues that we left farther on the development queue. Yeah, so one of the great things about having a way to integrate apps with the EHR is that apps can do practically anything. Anything you set your mind to and anything you can display inside a window for a user to see. But one of the challenges with apps is that you have to know which app to run and when to run it. And so, for example, if we have an application that helps clinicians make sense of the bilirubin levels in a newborn infant and provide decision guidance, is this a child who needs phototherapy or other therapy, or are these levels normal? If a clinician doesn't think to run that app, they're not going to benefit from the advice. So one of the big problems that we set out to solve was how to recommend exactly the right app to the right user at the right time, and even to look at kinds of integration that might be a little bit less than launching a whole app, but just integrating a snippet of advice or recommendations into the clinical workflow. So the CDS Hooks project is really about that. It's about watching what a clinician does while they're working with the electronic health record system all day long, and instrumenting that interaction, looking for specific points in the interaction, like opening a new patient chart, or prescribing a new medication, or reviewing a set of orders or lab tests that a clinician might be about to order. We look for those specific points in the workflow, and we say, we're going to provide a way for external services to offer their advice in line at those points. And the advice could be as simple as a little bit of text for the user to read, or it could be as rich as a link for them to click to launch a smart app from right inside the context of their electronic health record system, and really do a much more detailed workflow where they can provide some more inputs and get some advice that they can act on. Sure. So the Sync for Science initiative. Sync for Science is a project that is focused on a specific use case. It says, how can we help patients who might want to share their medical records with researchers? Because the truth is that if you're doing a research study, it's very easy to ask questions to your research participants. You can create a form and collect structured data by asking. But there's a rich history in the medical record that can be very hard to obtain in a structured way. It can be hard to obtain quickly or automatically and without a lot of barriers in the way. So today, oftentimes, the way that a researcher might get access to a medical record would be either on paper by asking for a medical record request and getting a stack of paper printed out, or they might work with a hospital to develop a custom technology. They might have to sit down and write special queries against the raw database and try to pull out the fields they care about. And both of those things are very slow and very expensive. So in the Sync for Science project, we've said, how can we automate this? How can we help patients share their data with researchers in a way that gives full control to the patients, but when a patient wants to, they can automatically approve that kind of access? And it's a project that we've been running through Harvard Medical School. There's a small technical team that's been helping to develop a specification and some guidelines, but we've been working very closely with the electronic health record community. So we've been working with Epic and Cerner and Allscripts and eClinicalWorks, working with each of these vendors to make sure they can build this technology into their own patient portal products. So that if I am a patient at a hospital or clinic that uses a patient portal from one of those vendors, I have a consistent way that I can approve an app to access my data. And the cool thing is that under the hood, we're using all those same standards that we've been talking about. We're using the Smart on Fire API to do that approval process. There's an OAuth workflow using a standard set of specifications to let a patient give access when they want to. And then we're using the FHIR resource definitions to be able to fetch specific kinds of data like medications or allergy lists or lab results or immunizations and on down the list. So it's been a really exciting project to see this technology go from a set of use cases on paper or on our website to now being implemented inside of patient portals from some of the biggest electronic health record vendors in the country. It's been a very interesting course for me over the last 7 years, which is to say, when I started, I was pretty naive about the pace of progress, and I thought that things might move faster. And the longer that I stayed involved and the more that I saw what it took to really enable change inside of these organizations, the more I've been surprised in a positive way by how much we've been able to achieve in this time. So the biggest leap that I saw us make was from talking about this work as a research project, as a cool idea about what the future could look like. And if I go back and I look at the slides that I was presenting in 2010, 2011, 2012, they were really focused on this technology as a vision for the future, but not as a reality. And then if I look at what started to happen 2013, 2014, 2015, vendors started picking up this technology and saying, we can use this to solve real problems that our customers are asking for. we can use this to extend the features that our electronic health record systems have by really taking advantage of the wide market of app developers who have good ideas about how to work with clinical data. So I would say that from where I sit right now, I've been really positively surprised by how quickly we've been able to make this progress. And I think that a major factor in our progress has been keeping the scope small enough to feel like it's not too far over the edge. And so I'm talking to you right now from San Diego at the end of a working group meeting of the Standards Development Organization, Health Level 7. We've been here for a week working with folks across the world who are helping to define some of these healthcare standards. And one of the big challenges working with a group like this is everyone is really passionate and has huge aspirations about what they'd like to accomplish in this space. But there's always a very careful balancing act between what you would like to see happen and what you can really make happen in a short time frame. And I think a big factor in their success has been focusing on the sort of short to medium term. So predictions are so challenging. When I think about the kinds of work that we've been doing, it's been focused a lot on workflow. It's been focused a lot on how do we put the right app in front of the right user at the right time. And I think that's incredibly important in today's install base, where there's a certain way that EHRs look and feel, and they have certain capabilities built in. But honestly, it's unrealistic to expect the base product to develop these neat, new, sophisticated features in every possible direction. So being able to open up that window and launch an app is really important. I don't know if I'll predict, but I'll say that I hope in 10 years, this whole paradigm may be turned on its head, which is to say we won't necessarily be working with EHRs that look and feel the way that today's systems do. We may have very tailored systems that are focused on the particular tasks that our user is trying to do. And rather than launching an app from inside a system like that, I think that the data will begin to become more of the central focus of the platform. We'll almost see an inversion of the control so that rather than the EHR being the central focus, the data will become the central focus, and we'll be able to construct the kinds of workflows we need around those data. That's a really abstract concept, but to drill that home maybe a little bit better, I would say that I hope in that time frame, what we'll have is individual systems that know how to take care of patients with specific diseases, for example, and provide a really tailored workflow and experience for making the right choices and incorporating patient preferences and feedback from patients into that kind of workflow. Thank you very much. It's been a pleasure.